Thanks, Mark. That was amazing. I wonder if you could elaborate a little bit more regarding some of the cultural changes that had to happen within the field to accept that translational paradigm.
Yeah, so I think what's not perhaps reflected in the publications is that there were many workshops like this where people actually argued about this quite vehemently. And there were many people who believed that one would never get rid of interferon, that interferon was a mainstay. There were others that really argued you couldn't put these drugs together. It did represent a major shift, both in terms of the thinking. One of the challenges that hepatitis C faced is that it was a liver disease. Keep in mind, the first studies were done with ALT. But what was ultimately developed were antivirals, classic antivirals with resistance and synergy, additive effect, and that was a major paradigm shift. But the regulatory shift was actually quite amazing to watch. We worked many workshops or meetings where studies were planned. It was always interferon, ribavirin, plus new drug X or new drug Y. There was never a paradigm shift until this very critical study that came out of New Zealand, which said, wait a minute, this virus may not actually be what we thought it was. But up until 2011, no one truly envisioned what treatment would look like today. If you had asked me in 2010, would we get here, I would have said no. We're going to make incremental progress, but we're still going to fail in certain areas. So it did take several things. One was the translation of the in vitro models to humans, and two was modeling. There were very nice models conducted that suggested that if you combine these drugs, it should work. Now, the difficulty is convincing regulators that modeling can be translated, and that's the success we've had, is that the in vitro work translates really nicely to 3-day dosing, and 3-day dosing translates really nicely to a curative effect. So it looks like it went relatively smoothly, but it didn't. In fact, until 2011, most people thought interferon would still be around today. They were wrong. I don't know if that touched on what you want to get.
Yes, thank you.
Other questions or comments?
So on modeling and simulation in the field, the acceptance among clinicians and researchers, it seems to have had a very good uptake. So what do you think was different there? We're having a harder time in our areas.
Well, yeah, that's a good question. I wouldn't say that it was taken up without some resistance. There was a lot of belief that hepatitis C was that these models wouldn't translate to success. I think what the difference was the ability to show translation to humans quickly. So in other words, you've got your in vitro model that suggests these drugs work as antivirals. You've got a model suggests you've combined a polymerase plus, let's say, a protease, it should work. But then what you had is within 3 days of human dosing, you could see these very rapid declines. So I think what really swayed clinicians was the ability to see in a human model the translation of that really quickly. And that's one of the major advantages that hepatitis C has, I think, over tuberculosis, is with this dynamic virus that can be easily measured by PCR, you can measure this quickly. The other advantage that we have is the drug delivery. A liver infection has an inherent advantage. If you swallow a pill, the first place that medication goes is to the liver, and very high concentrations are achieved. So although we looked at blood levels of various drugs, it's quite likely the liver levels, which are really hard to measure, and no one's done that quite successfully, are even higher. Now there is a flip side to that. Some of these drugs actually cause liver toxicity in patients with bad liver disease. But I think the key success was early translation. If you show a clinician a phase 1 study with impressive results, that's what led to people willing to take risk. And there was risk. There's no question about that.
We have a question back here. Oh, go ahead, sir. Go ahead. No, go. Fine.
Yeah, so now that we have effective therapy The challenge now is to identify people who probably are infected but never got tested, especially healthcare workers. So what is the system going forward in terms of reaching to these people?
Yeah, so the question was really about trying to expand diagnosis. So it varies by region. In the United States, there's a recognition that 75% of the infections actually exist among people born between 1945 and 1965. So there is a recommendation from the CDC that every person in the U.S. That's in this so-called baby boomer generation be screened. Now, there is not exactly robust uptake by primary care clinicians, although I think that certainly we are seeing more uptake as people see the opportunity for cure. Now, globally, I think the biggest challenge is how do you even tackle this? My colleague Sunil Solomon recently did a response-driven sampling of hepatitis C and HIV where they followed persons who inject drugs, and they would then get the names of 5 other people, they would test them, and the burden of disease undiagnosed in places like India, China, the Middle East, places like Egypt is just staggering. So I think the model that we're trying to get to is a point-of-care test, it's a finger stick right now, where you get an antibody response, perhaps a point-of-care antigen test or viral RNA test, followed by delivery of a pan-genotypic regimen without testing. In fact, within the ACTG, we're developing a protocol known as MIN-MON, where we'll simply do that. Antibody, virus, treat. No monitoring.
Thank you. I'm Andy Vernon, CDC. I've got 2 questions. The first is that I don't actually understand the surprising, what's surprising about the development, because given, as one develops, given the example of HIV, I would have thought, well, gee, if you find enough out about the virus, you'll identify several targets. You're going to need multi-drug therapy, and it ought to be pretty straightforward. It just takes time to get the information on those targets and put all that together. So that part seemed not surprising. The second question has to do with the cost issues and how you see the cost issues being addressed in order to have impact globally, because that's certainly an issue that we face in TB with the same kind of drug costs for new drugs and a desire to begin to expand use of those drugs globally.
So the point about the antiviral development, I think you're right. Once there was the ability to understand the virus life cycle, but one of the challenges is the virus was identified in '89, so you're talking about a span of about 10 years. So once the virus was worked out, it was definitely a very possible project. But you have to keep in mind that the experts in this area were liver specialists. And interferon, which is a mystical drug and how it works, was the treatment choice. It led to some mysticism about this. And there were many who came from the HIV side of it who thought, boy, this should be easy. Yeah. With respect to the cost, we are seeing the cost decrease in the U.S. as there are now multiple regimens. And although it might be nice to take one pill once a day for 8 or 12 weeks, it's not necessary. There are you only have to kill the virus once. And there are other ways to do that. We're seeing competition, which is driving the price down, but still very expensive in developed countries when you look at the cost, and that cost has to decrease further. That's a whole other discussion there, but in the rest of the world, these drugs are being produced by generic manufacturers. Decladisvir was the first medicine, the first NS5A inhibitor turned over to the medicine patent pool. So Fosbuvir is being produced, and it's estimated you can get a decladisvir-sofosbuvir combination down to about $200 for a total treatment course. Now the challenge is with current funding for hepatitis C, both diagnosis and treatment, $200 is still out of reach of many regions. So it's the cost coming down and then greater investment. And honestly, we haven't seen that investment even here in the U.S. into populations at high risk.
Thank you.
Yeah.
Yes, good morning. Wim van der Velde from the TB Cab. I understand that in the early days of the hepatitis, Chiron filed patents for the diagnosis and on the virus itself. And I understand from drug developers that that was somehow a barrier in the development and also increased the cost overall. Plus, there's another trend that we see that nowadays in the product developers, they push for their own in-house combinations rather than for what is the best combination for the patients. Are there any lessons to be learned for the TB world?
Well, you raised two very good points. One is that there was a reluctance early on because of the patents filed by Chiron, which was where Michael Houghton and his team worked that discovered the virus. There was a reluctance, and that had to be worked out legally before major pharmaceutical companies were to invest. So that's the first thing. The second thing is that there continue to be issues about combining drugs from different manufacturers. We haven't seen that. Hepatitis C has not unfolded in a very cooperative fashion. In fact, decladisvir, sofosbuvir would likely have been available earlier than we ultimately saw drugs available if the two had been combined, and that was the subject of some discussion. But it leads to the other point, and one of the things behind the hepatitis C model was the incentive for drug development is really the 3 to 4 million Americans and millions of Europeans and other countries that pay for drugs to develop. So there is this, this is part of the incentive, but I do think there was a big push even now to try to get companies to cooperate. That has not been successful in hepatitis C, and that's not one of the features I would describe as hep C's success story, is cooperation. That hasn't been seen, nor has getting the cost down to make access to more folks. Many states in the United States, I use the analogy of the country of Georgia, where they're trying to eliminate hepatitis C, versus the state of Georgia, where there are still major restrictions through payer systems on who can be treated, only those with advanced liver disease. So we have a long way to go. I don't mean to imply by any stretch this is smooth sailing. It's not. So I'm not quite out of work yet.
Other questions for Dr. Sikowski before we break? Okay, thank you.
Thank you.